Most knee pain isn't mysterious at all. It just hasn't been explained properly yet. Until tonight. I'm a physiotherapist, and knee pain is one of the things I see most often in clinic, in people of every age, every activity level, and every lifestyle. The first reason is one of the most common causes of knee pain I see in clinic, and it goes by a name that sounds more alarming than the reality warrants. It's called Patellofemoral pain syndrome, which is simply a formal way of describing pain that comes from the kneecap and the area directly around and beneath it. To understand why this happens, it helps to think of the kneecap as a small bone designed to glide smoothly up and down in a groove on the front of the femur each time your knee bends and straightens. For this to happen correctly, the muscles on either side of the knee need to be pulling in a reasonably balanced way, keeping the patella tracking straight in that groove. When one side is pulling harder than the other, which happens far more often than most people realize, the kneecap gets drawn slightly off-center. Instead of gliding smoothly, it presses unevenly against the underlying bone. That uneven pressure, repeated with every step, every flight of stairs, every time you lower yourself into a chair, gradually becomes painful. The most common reason this tracking goes wrong is a combination of weakness in the inner quadriceps muscle, specifically the vastus medialis, the teardrop-shaped muscle just above and to the inside of the kneecap, and weakness in the hip muscles, particularly the glutes and hip abductors. When the muscles on the outside of the thigh are relatively stronger or tighter than those on the inside, they pull the kneecap outward from where it should be tracking. When the hip muscles are weak, the femur itself tends to rotate inward during walking and squatting, which changes the angle at which force arrives at the kneecap even further. This is why patellofemoral pain tends to be worst going downstairs rather than up, worst when you've been sitting for a long period with the knee bent and then stand, worst during squatting movements or sitting in low chairs. All of these positions place the most compressive force through the kneecap, and if it isn't tracking where it should be, those are exactly the moments it complains most. The pain is also often described as a vague, diffuse ache that's hard to pinpoint precisely, sometimes felt behind the kneecap, sometimes around its edges, sometimes radiating slightly above or below it. People often describe it as a deep ache rather than a sharp point, which reflects the nature of the pressure being distributed across the undersurface of the patella rather than concentrated at one spot. The fix involves two main areas. The first is strengthening the inner quads specifically through exercises like terminal knee extensions, where a resistance band around the back of the knee is used to push the leg straight from a slightly bent position, focusing deliberately on that final range of extension where the vastus medialis is most active. Short arc quads, lying on your back with a rolled towel under the knee and lifting the heel to straighten the leg fully, are another accessible option that places almost no compressive force on the knee itself. The second area is strengthening the hip muscles, particularly through side-lying leg raises, clamshell exercises, and single leg squat variations where attention is paid to keeping the knee tracking directly over the second toe rather than drifting inward. Footwear and surface also matter here. Flat, unsupportive shoes on hard surfaces increase the forces transmitted through the knee with every step, which compounds the problem considerably. Supportive footwear with adequate cushioning helps reduce that cumulative load. I treated a young woman in her mid-20s, a graduate student who had started running the previous year as a way to manage the stress of her final year of study. The pain appeared gradually, first as a vague ache after her runs, then as a persistent soreness whenever she climbed the stairs in her apartment building, and eventually as discomfort that appeared even during long study sessions at her desk when she stood up after sitting for hours. She was convinced she'd torn something and had been putting off coming in, partly out of worry about what she might be told. When we assessed her, the knee itself was structurally completely fine. What we found instead was noticeably weak hip abductors and a quadriceps imbalance that meant her kneecap was tracking slightly outward with every step she took. We stopped her running temporarily, not indefinitely, just for long enough to allow the irritation to settle and the strengthening to gain some traction. 4 weeks of targeted hip and quad work, 3 sessions a week, nothing complex or time-consuming, followed by a gradual reintroduction of running, with some attention paid to her foot strike pattern. Within 8 weeks of starting, she was running pain-free, further than she'd been managing before the pain began, and without the background soreness that had followed her around during the previous months. The most reassuring thing about patellofemoral pain, once you understand what's driving it, is that it responds extremely well to the right exercises. It rarely requires imaging, medication, or anything invasive. It just needs the right muscles to start doing their job properly again. The second reason tends to affect people who do repetitive activities, particularly anything involving a lot of jumping, running, or squatting, though it can develop in people who do far less than that as well. It's called patellar tendinopathy, sometimes referred to as jumper's knee, though the name is a little misleading because you certainly don't need to jump to develop it. The patellar tendon runs from the bottom of the kneecap to a bony bump at the top of the shin, called the tibial tuberosity. Its job is to transmit the force generated by the quadriceps down into the lower leg, allowing you to extend your knee powerfully. Every time you jump, squat, run, or climb stairs, this tendon absorbs and transmits significant force. Over time, if the load placed on the tendon consistently and repeatedly exceeds its current capacity to adapt, the tendon tissue begins to show internal changes. Small disruptions in the organized collagen fibers that make up the tendon structure. These changes reduce the tendon's ability to handle force efficiently and make it progressively more sensitive. The pain from patellar tendinopathy is almost always felt at a very specific location, right at the bottom of the kneecap, at the point where the tendon attaches. It tends to be worst at the beginning of activity, stiff and painful for the first few minutes, then often eases somewhat as the tendon warms up, before returning after activity ends and things cool down again. In more progressed cases, it becomes persistent and present during everyday activities, like walking or prolonged sitting. What makes tendinopathy fundamentally different from other kinds of knee pain is that rest alone doesn't fix it. In fact, prolonged rest tends to make tendons more sensitive and less tolerant of load when activity eventually resumes. Tendons need mechanical loading to signal the repair and adaptation process. The issue isn't the load itself, it's the gap between the load being applied and the tendon's current capacity to handle it. The solution, counterintuitively, is to progressively close that gap, not to remove load entirely. The cornerstone of treatment for patellar tendinopathy is heavy, slow resistance training of the quadriceps. Exercises like slow squats, leg press, or decline board squats, performed at a pace of 3 seconds down and 3 seconds up, progressively loaded over weeks. The slow speed is important because it places more time under tension on the tendon tissue, which is the mechanical stimulus tendons respond to best. These exercises are typically performed at a level that produces some discomfort, around a 4 or 5 out of 10, which is acceptable and expected, provided the pain settles back to baseline within 24 hours afterward. A pain that lingers for longer is a signal to reduce the load slightly before progressing again. Alongside this, any highly reactive activities like running, jumping, or deep plyometric work are typically reduced or modified during the initial phase, not eliminated entirely, but managed carefully to prevent the tendon from remaining in a persistently irritated state while the adaptation work is happening in parallel. A man in his late 30s came to see me after 6 months of trying to push through what he'd assumed was a minor irritation beneath his right kneecap. He was a recreational basketball player, training twice a week with a casual team, and had gradually noticed pain that was now present not just during basketball, but during his daily walk to work and when taking stairs. He'd tried a full 2 weeks of rest at one point and found it made no lasting difference. We started him on a structured tendon loading program, slow, heavy single-leg press and decline squats 3 times a week, combined with a temporary reduction in basketball to 1 session a week, modified to avoid the most explosive movements. At first, the exercises felt counterintuitive to him. He was loading something that hurt. But the reasoning made sense once it was explained, and he committed to it. By week 12, his pain during daily walking had essentially resolved. By week 16, he was back to full basketball without modification, and for the first time in months, his knee felt genuinely reliable rather than something to be cautiously managed around. The insight that changes everything with tendinopathy is understanding that the solution isn't less load. It's the right load, applied consistently and progressively over enough time for the tendon to actually change. The third reason produces a very distinctive localized pain on the outside of the knee that's hard to confuse with anything else once you know what you're looking for. It affects runners and cyclists most commonly, though not exclusively. It's called iliotibial band syndrome, or IT band syndrome. The iliotibial band is a thick, dense band of connective tissue that runs down the entire outer side of the thigh, from the hip to just below the outer edge of the knee, where it attaches to a bony prominence on the tibia. It plays an important role in stabilizing the outer side of the knee during movement. During running or cycling, the IT band repeatedly passes back and forth across that bony prominence on the outer knee, with every step or pedal stroke. When the band is tight, or when movement mechanics place excessive compression and friction through that area, inflammation develops in the underlying tissue, producing pain that is almost always precisely localized to the outer side of the knee, often described as sharp or burning, and which typically worsens after a predictable amount of activity, not immediately, but appearing reliably after a certain distance or duration, like a clock 20 minutes into a run, or at a specific point on a cycling route. The underlying cause is almost always traced back to a combination of hip weakness and training load. Weak hip abductors, the muscles on the outer side of the hip responsible for keeping the pelvis level during single leg loading, allow the femur to drop and rotate inward with each stride, which increases the compressive force the IT band experiences over that lateral knee prominence. Sudden spikes in training volume, running on cambered roads that tilt one foot lower than the other, worn-out footwear, and a pattern of running with excessive inward knee drift all contribute. The fix involves several components working together. Hip strengthening is the most important element, targeting the gluteus medius in particular, through lateral band walks, side-lying leg raises, and single leg squat variations with deliberate attention to maintaining pelvic level and knee alignment. A temporary, partial reduction in the aggravating activity, not complete rest, but enough to allow the local inflammation to settle, is usually necessary in the first few weeks. There's a widespread misconception worth addressing here. A great many people with IT band syndrome are told or read online that they should foam roll the IT band itself, applying pressure directly to the outer thigh. The iliotibial band is a very dense piece of connective tissue. It doesn't lengthen or release meaningfully with foam rolling in the way that muscles do. What does respond to soft tissue work is the surrounding hip musculature, the gluteus medius, the tensor fascia lati, the hip external rotators, all of which are softer, more pliable, and more responsive. Foam rolling the outer thigh directly tends to be painful without producing much useful change. Addressing the hip muscles above and improving the mechanics that drive the problem in the first place is where the actual benefit lies. I had a patient, a 40-year-old man who had taken up running the previous year and was training for his first half marathon, who came in with exactly this presentation. Pain on the outside of his right knee, appearing reliably after about 25 minutes of running, and which had forced him to stop short on each of his last 3 planned long runs. He was 4 weeks from his race and genuinely anxious about whether he'd make it to the start line. Assessment showed significantly weak right hip abductors compared to the left, and a noticeable inward collapse of the right knee during single-leg squat testing. Exactly the pattern that drives IT band friction. We couldn't fully resolve the underlying strength deficit in 4 weeks, but we could address the most immediate contributors. Improve his hip activation during running through specific pre-run exercises, and manage his training load carefully to keep his fitness intact while giving the inflamed tissue time to settle. He made it to the race and finished it. The proper rehabilitation continued for another 2 months after that, building the hip strength that would prevent recurrence over the longer term. But the race was achievable because we addressed the most pressing mechanics in time, rather than either pushing blindly through or stopping entirely. The fourth reason involves a structure that gets mentioned frequently in knee pain conversations, often in language that sounds far more serious than the situation actually requires: the menisci. Those 2 crescent-shaped pieces of cartilage sitting inside the knee joint, one on the inner side, one on the outer side, absorb shock, distribute load, and contribute to the knee's overall stability. Meniscal problems can arise in 2 quite different ways, and it's worth understanding the distinction because they have meaningfully different implications. The first is an acute injury, typically from a twisting force applied to the knee during sport or sudden movement, where the meniscus tears more dramatically. This tends to produce immediate pain, rapid swelling, sometimes a catching or locking sensation where the knee won't fully straighten, and occasionally a feeling of instability. Acute tears of this kind, particularly in younger people or those involving significant structural disruption, often require assessment from an orthopedic specialist to determine the best path forward. The second type is what's called degenerative meniscal change, which is quite different in nature and far more common, particularly in people over 40. Rather than a sudden tear from trauma, the meniscal tissue gradually becomes less resilient over years, sometimes developing small tears or areas of fraying that build up slowly without any single dramatic event, and without the person necessarily being able to point to anything that caused it. A scan is done, the report uses the word tear, and the person reading it understandably assumes the worst. Here's what that word tear doesn't tell you. Degenerative meniscal changes are present on MRI in a very large proportion of middle-aged and older adults who have no knee pain at all. Studies that have scanned the knees of symptom-free people in their 40s, 50s, and 60s routinely find these changes. This doesn't mean the findings are irrelevant to someone who does have pain, but it does mean that the presence of the change on a scan alone doesn't determine the level of pain or limitation someone experiences. The two don't have a simple, reliable relationship. It's also worth understanding that the appropriate response to a meniscal tear depends considerably on the person's age and the nature of the tear. In younger people, teenagers, and those in their 20s and early 30s, meniscal tears are more likely to be of the acute traumatic variety, and the tissue in younger knees has better blood supply and healing potential than in older knees. Some regions of the meniscus, particularly the outer third where blood supply is better, have genuine capacity for healing or surgical repair in younger patients. For these situations, specialist assessment to determine whether the tear is in a repairable zone is genuinely important, and surgery may be the right path. For older adults with a degenerative variety, the picture is quite different, and this is where the research has most clearly shifted the conversation toward conservative management as the appropriate starting point. The research on how to manage degenerative meniscal tears has shifted substantially over the past decade. Multiple large, well-designed trials have compared surgery, specifically the arthroscopic procedure of trimming or shaving the torn area, against structured physiotherapy programs. These trials consistently showed that physiotherapy produced outcomes equal to surgery, and in some measures better, for the degenerative variety of meniscal change in middle-aged and older adults. Physiotherapy is now widely considered the appropriate first-line approach in most guidelines, with surgery reserved for cases where conservative management has genuinely been tried and failed. What that conservative management looks like is a graduated strengthening program focused on the muscles surrounding the knee, particularly the quadriceps and hip muscles, to reduce the load the meniscus itself has to absorb with every step, and to improve the overall stability and shock-absorbing capacity of the joint as a whole. Low-impact activities like cycling, swimming, and level walking tend to be well tolerated. Deep squatting and high-impact activities are typically modified in the early stages until irritation settles. A woman in her early 50s came in after her GP had arranged an MRI following several months of intermittent pain on the inner side of her right knee, worse with getting up from low chairs, climbing stairs, and prolonged walking. The report described a degenerative tear of the medial meniscus. She arrived expecting to be referred for surgery and was surprised and initially somewhat skeptical when I explained that the evidence actually supported starting with a structured rehabilitation program. She decided to try 3 months of progressive quad and hip strengthening with practical modifications to her daily activities during the most provocative movements. By the end of that period, her pain was minimal and her function had returned to the point where she was doing everything she'd been avoiding. She never went on to have surgery. The knee hadn't changed structurally. What had changed was how well the muscular system surrounding it was absorbing and managing the loads that had previously been going straight through the damaged tissue. The meniscus tends to be described in terms that make it sound irreversibly fragile. For the degenerative variety, at least, the surrounding muscle system can do a remarkable amount to compensate for what's changed inside the joint. There is something worth pausing on before we go further. I am not a doctor or physician. I am a physiotherapist. What we're going through tonight is educational content, an explanation of the patterns I see most commonly in clinical practice. It is not medical advice. If your knee pain is severe, involves significant swelling, locking, giving way, or follows a specific traumatic event, please consult a qualified healthcare professional rather than relying on this alone. With that said, let's continue. There's still more worth understanding. The fifth reason is a condition whose name tends to land with a kind of weight and finality that isn't always deserved: osteoarthritis of the knee. Osteoarthritis is the gradual breakdown of articular cartilage, the smooth tissue covering the ends of the bones inside the joint. As that cartilage wears down over time, the bones lose some of their cushioning and gliding surface, which can cause pain, stiffness, and swelling. In more advanced cases, the joint space visible on an X-ray narrows noticeably, and sometimes bony changes develop at the joint margins. Here's the part that almost never gets said clearly enough. There is often a surprisingly poor relationship between what a scan or X-ray shows and the amount of pain or limitation someone actually experiences day to day. Plenty of people have significant arthritic changes on imaging and live completely functional, active, comfortable lives. Others have relatively mild imaging findings and significant pain. The amount of cartilage remaining is only one part of a much more complex picture, and it's far from the most important determinant of how someone feels. What actually determines how someone with knee osteoarthritis functions on a daily basis depends enormously on the strength and conditioning of the surrounding muscles, their overall body weight, how physically active they remain, and the quality of their movement patterns. Exercise is consistently the most effective intervention for managing osteoarthritis symptoms, consistently outperforming medication alone in research trials for reducing pain and improving function over the medium and long term. This is not a controversial finding. It's one of the most robust conclusions in musculoskeletal medicine. This surprises a great many people. The instinct when a joint is painful is to protect it, to move less, to avoid putting load through it, to rest. But in the case of osteoarthritis, that instinct tends to accelerate the very decline it's trying to prevent. Articular cartilage has no blood supply of its own. It receives its nutrients from the synovial fluid inside the joint, which is pumped in and out by movement. Reduce movement, and you reduce that nutrient delivery, weaken the surrounding muscles, and you allow more of each mechanical load to pass directly through the joint surface rather than being absorbed by the muscular system. Both of these factors worsen the experience of osteoarthritis steadily over time. There's one more layer worth understanding here. In long-standing osteoarthritis, the pain system itself can become sensitized over time, meaning the nervous system, through repeated exposure to pain signals from the joint, gradually lowers its threshold for generating pain. The joint doesn't have to be under significant mechanical stress to produce a pain response anymore, because the system has become more alert and reactive than it needs to be. This phenomenon, sometimes called central sensitization, is part of why osteoarthritis pain can sometimes feel disproportionate to what the scan shows, and why the same degree of structural change can produce very different experiences of pain in different people. This is also one of the reasons that exercise, and specifically the gradual progressive kind, is so important beyond the purely mechanical benefits. Regular graded activity has been shown to have a direct modulatory effect on pain sensitivity over time, essentially helping to recalibrate a nervous system that has been running on high alert. This is a meaningful benefit that ice packs and rest cannot provide. The approach that works is graduated exercise, starting from whatever level is currently comfortable and progressing carefully with a focus on building quadriceps and hip strength, maintaining range of motion, and keeping aerobic fitness up through low-impact activities. Water-based exercise is particularly well tolerated for people who find weight-bearing exercise too uncomfortable to start with, because the buoyancy significantly reduces the load through the knee, while still allowing meaningful muscular work. As strength builds and pain settles, progressively more weight-bearing activity is introduced. I worked with a man in his early 60s who had been told by a surgeon that he would likely need a knee replacement within the next few years. He came to see me not expecting much, just curious whether anything could be done in the meantime to keep him functional and comfortable. His quadriceps were noticeably weak, and he'd largely avoided exercise for the previous year out of a genuine fear that activity would accelerate the damage. He'd been resting protectively, and his knee had been getting gradually worse despite that rest. We started very conservatively, seated leg strengthening, pool sessions twice a week, and a gradual walking progression on flat ground. From those foundations, we built steadily over the following 6 months. A year after his first appointment, his pain levels had reduced substantially. His walking distance had more than doubled. When he went back for his surgical review, the consultant agreed that a knee replacement was no longer being discussed as something imminent. Nothing structural had changed in his knee. What had changed was the strength and resilience of everything supporting it. Osteoarthritis is a condition that is genuinely manageable for a great many people, not through reversing what has happened to the cartilage, which isn't currently possible, but by building a stronger, better conditioned system around whatever is left. The sixth reason is one we touched on briefly in the opening chapter, but it deserves its own full explanation because it accounts for so much more knee pain than most people realize. It's weakness in the hip and glute muscles and the mechanical consequences that weakness has for the knee below. The knee sits between the hip above and the ankle and foot below it. It's influenced by both directions. When the hip muscles, particularly the gluteus medius and the hip external rotators, aren't adequately controlling the position of the femur during single leg loading activities like walking, running, and stair climbing, the femur drifts inward and rotates internally. This changes the angle at which force is delivered to the knee with every single step. The kneecap is pulled toward the outer side of its groove. The inner structures of the knee experience more stress. The outer structures experience more friction. And across hundreds or thousands of steps a day, that altered mechanics translates into a cumulative load the knee wasn't designed to absorb. This pattern is often visible during a simple single leg squat. A knee that collapses inward toward the opposite foot, sometimes called dynamic knee valgus, is a clear sign that the hip above it isn't providing sufficient control to keep the femur in its optimal position. The person doing the squat often doesn't feel unstable because the compensation has become automatic and familiar. But from a mechanical standpoint, it represents a meaningful alteration in the forces passing through the knee with every repetition of that movement. What makes this pattern particularly common is that it's largely a consequence of how most modern lives are structured. Long hours of sitting reduce the neural activation of the glutes and hip abductors, making them slower to engage and less capable of generating force quickly during the dynamic demands of walking and stair climbing. Over years, a meaningful strength deficit develops, not in the muscles the body uses most often, but in exactly the muscles responsible for protecting the knee from excessive inward loading. The fix is progressive hip and glute strengthening done consistently over weeks to months. Side-lying clamshells, resistance band lateral walks, single-leg glute bridges, and controlled single-leg squat training with feedback are all effective tools. The goal isn't simply building strength in isolation. It's teaching the hip muscles to engage rapidly and appropriately during the loading phases of everyday movement, which requires practice, repetition, and enough time for the neuromuscular patterns to become automatic. I worked with a teenage girl who ran for her school's cross-country team and had been dealing with knee pain across 2 consecutive training seasons. Multiple people had attributed it vaguely to growth spurts and told her she simply had to manage it. When I watched her run, the pattern was immediately apparent. Her right knee collapsed noticeably inward with every single stride, not dramatically, but consistently, on every step, for the entire duration of the run. Her hip abductor strength on that side was measurably weaker than on the left. We spent 6 weeks on targeted hip work before making any changes to her running at all. Once her hip strength had improved to a level where the inward collapse was no longer visible during single-leg testing, we reintroduced running gradually, starting with short, easy distances and building from there. Her knee pain did not return that season. She went on to have the pain-free training year she'd been hoping for through 2 previous seasons of managing around something that had a clear and addressable cause the whole time. There's one additional dimension to hip weakness and its effect on the knee that doesn't get mentioned often enough. Beyond the purely mechanical effect of the femur drifting inward, hip weakness also compromises proprioception at the knee, the joint's ability to sense its own position in space and respond appropriately to sudden changes in load. Proprioception is mediated by small sensory receptors in the muscles, tendons, and ligaments surrounding the joint, and it depends partly on the muscles being active and engaged. When the hip muscles are weak and underused, the feedback loop that allows the knee to react quickly and accurately to unexpected forces, a slightly uneven step, a sudden change of direction, is less effective. This is part of why people with hip weakness often describe a subtle sense of the knee feeling unreliable, not quite there, particularly during activities that involve rapid or unpredictable loading. Strengthening the hip doesn't just change the mechanics of how load is delivered to the knee, it also improves how well the knee can sense and respond to what's happening around it. The knee is the site of the pain. The hip is very often the source of the problem. The 7th reason concerns something that affects every step we take and yet receives almost no attention unless something visibly goes wrong. It's movement mechanics, the specific patterns of how you walk, run, or climb stairs, and how small deviations in those patterns accumulate into meaningful stress at the knee over time. There are several common mechanical patterns worth understanding here, and what makes this reason both important and hopeful is that movement patterns, unlike structural changes, are genuinely modifiable. They develop gradually from habits, and they can be changed gradually through attention and practice. The first is overpronation of the foot, where the arch collapses excessively inward during the loading phase of each step. Because the foot and lower leg are connected structurally, this inward collapse at the foot creates an inward rotation of the shin, which travels upward and alters the alignment of the knee. It's another version of the inward knee drift we've discussed in previous chapters, but originating from below rather than above. For people who overpronate significantly, every single step places the knee in a slightly compromised position. Across the thousands of steps that make up a typical day, the cumulative effect is substantial. The second common pattern is what's called overstriding in runners, where the foot lands well ahead of the body's center of mass, usually with the heel striking first and hard. This creates a braking force, with every stride sending a spike of impact load back up through the ankle, shin, and knee with each landing. A slightly shorter stride, with the foot landing closer beneath the hips, reduces that impact significantly and distributes load more favorably across the lower limb. This is one of the reasons that experienced runners often find their pain resolves when they increase their running cadence slightly, taking more, shorter steps rather than fewer longer ones, even without changing anything else about their training. The third pattern is reduced hip extension during walking or running, where the hip doesn't fully extend behind the body during the push-off phase of the stride. This tends to increase the compensatory demand on the knee and calf to generate the propulsion that should partly be coming from the hip extensors. Again, This traces back to the hip weakness and hip flexor tightness we've encountered in earlier chapters, the same underlying patterns expressing themselves in yet another way at the level of the knee. For walking, simple awareness of foot placement, stride length, and trunk position can produce meaningful reductions in knee load without requiring any equipment at all. For running, a gradual increase in cadence is one of the most evidence-based approaches to improving running mechanics, and it can be achieved as simply as running to a metronome app or a playlist set to a specific beats per minute tempo. Footwear remains relevant here. Someone who overpronates significantly may benefit from motion control or stability footwear that supports the arch and reduces that inward collapse during loading. Someone with a neutral or supinated foot pattern may do better in a more cushioned, neutral shoe. There is no universally best shoe. The right choice depends on the individual's foot mechanics, and getting properly assessed for footwear, rather than choosing based on appearance or brand, consistently produces better outcomes for people whose knee pain has a mechanical component. A runner in his late 40s, who had taken up distance running 3 years earlier, had tried 3 different pairs of running shoes over 2 years in an attempt to resolve knee pain that appeared predictably during longer efforts. When we carried out a slow-motion video analysis of his running, 2 things stood out clearly. He was significantly overstriding. His heel was landing well in front of his body with each step, creating a visible braking impact with every stride, and his foot was collapsing inward noticeably on the affected side during the loading phase. A change in footwear addressed the arch collapse, but the more meaningful change was a deliberate, gradual increase in his running cadence, which shortened his stride and dramatically reduced the impact forces visible in the analysis. 3 months of consciously retraining this pattern during his easy runs, using a metronome for the first several sessions until the new rhythm became automatic, eliminated his knee pain almost entirely without any other change to his training. The 8th reason is one that operates purely through load, and it connects directly and mechanically to everything else we've discussed tonight. Research has established fairly consistently that for every additional unit of body weight carried, the compressive force transmitted through the knee joint during walking is amplified by roughly 3 to 4 times that amount. This isn't a small effect. It means that a 10 kilogram difference in body weight corresponds to a 30 to 40 kilogram difference in the force the knee absorbs with every single step. Across 20,000 steps a day, a fairly modest estimate for an active adult, the accumulated difference in load over a single day is enormous. And that difference compounds across months and years. During stair climbing, that multiplication increases further still. The geometry of the knee joint means that even relatively modest differences in body weight translate into quite disproportionate differences in the force the joint absorbs with every step, across every hour of every day. For people carrying excess weight who are also experiencing knee pain, weight management is often a meaningful part of the longer-term picture. But it's almost never the whole story, and framing it as the primary or sole explanation tends to both oversimplify and discourage. Because losing weight takes time, often considerable time, and focusing only on that while ignoring the muscular and mechanical factors that can be addressed far more quickly tends to leave people waiting for relief that could start arriving much sooner. It's also worth understanding a nuance here. Muscle mass contributes to body weight, but muscle mass also absorbs load that would otherwise pass directly through the joint surface. Building strength in the quadriceps and hip muscles simultaneously adds some weight and dramatically reduces the proportion of each ground reaction force that reaches the cartilage and passive structures of the knee. This is part of why a well-designed strength program for knee pain can produce meaningful reduction in symptoms even without any change in total body weight, simply by changing how load is distributed between the muscular and passive systems with every step. A woman in her mid-50s came in after her orthopedic consultant had suggested that losing some weight before any further assessment would be beneficial. She arrived frustrated, feeling as though the weight had been identified as the entire problem rather than one factor in a more complete picture, and as though the most useful thing she could do was something that would take a very long time to show results. She'd been dealing with knee pain daily for 18 months and wanted to understand what else might be contributing and what she could actually do about it now. What we found, when we looked properly, was exactly what we've been discussing throughout tonight: weak hip muscles, limited quad strength, a tendency for her knee to track inward during loading. We focused our work primarily on strengthening those areas, while she simultaneously made gradual dietary changes with her GP. Over 6 months, a combination of modest, sustainable weight reduction and substantially improved muscular support around the knee reduced her pain more meaningfully than either would have done in isolation. The weight was a real factor. So was everything else. Addressing them together produced results that addressing either one alone wouldn't have. We've been through 8 reasons tonight, each with its own clear mechanism and its own path toward improvement. Before we finish, as we did when we went through lower back pain, there are a few common patterns in how people respond to knee pain that quietly get in the way of actually getting better. And they're worth naming honestly. The most common mistake is complete rest. The instinct is entirely understandable. Something hurts, so stop doing what hurts. But the knee does not recover well from prolonged inactivity. Cartilage needs movement to receive nutrients. Muscles need load to remain strong. The compensatory patterns that contributed to the problem only deepen when movement is removed. Gentle, modified activity within a tolerable range is almost always more beneficial than rest, even in the early stages. This is one of the most consistent findings in rehabilitation research. The second mistake is treating all knee pain as though it were the same condition. We've gone through 8 distinct causes tonight, each with a different underlying mechanism and a different solution. What works for patellar tendinopathy, progressive loading, is not the right approach for an acutely irritated patellofemoral joint. What helps IT band syndrome, hip strengthening, and load management is different from what helps osteoarthritis. Identifying the actual type of knee pain you're dealing with, ideally with some professional guidance, matters enormously for knowing what to actually do about it. The third mistake is focusing only on the knee itself while ignoring the hip above it and the foot below. The knee is the site of the pain in the majority of cases we've discussed tonight. It is almost never the sole origin of the problem. Hip weakness, hip tightness, foot mechanics, and global movement patterns are implicated in the majority of knee pain presentations. Treating only the knee through local ice, compression, or knee-specific exercises alone, while leaving those upstream and downstream factors completely unaddressed, tends to produce only temporary and frustrating relief. The fourth mistake is expecting rapid results. The structures involved in knee pain, tendons, cartilage, and the muscular system around the joint change slowly. Meaningful improvement in tendon health typically takes 8 to 12 weeks of consistent loading before it's clearly established. Strength gains in the hip and quad sufficient to meaningfully change loading mechanics require a similar duration of consistent training. This isn't discouraging news. It's simply accurate information about how these tissues respond to the right stimulus. Understanding this up front changes how people relate to the process. They stop expecting to feel dramatically better after 2 weeks and start building the patient-consistent habits that actually produce lasting change. And the fifth mistake is waiting too long when something isn't improving. Knee pain that involves significant swelling, locking, a sensation of giving way, complete loss of range of motion, or pain that follows a specific traumatic event warrants proper clinical evaluation, not continued self-management. There is a sixth pattern worth naming as well, and it's one that's particularly easy to fall into, with knee pain specifically. It's relying on passive interventions, ice packs, anti-inflammatory gels, compression sleeves, massage, ultrasound treatments as the primary or sole approach to management. These things can have a role, particularly in the early stages, when reducing acute irritation and pain allows the person to begin moving more comfortably. But they don't change the underlying mechanical and muscular factors that caused the pain in the first place. Passive treatments provide relief. Active treatments, the strengthening, the movement pattern work, the hip rehabilitation, produce change. The goal is always to use the former to make the latter possible, not to substitute one for the other indefinitely. The most common version of this I see is someone who has been icing their knee and wearing a compression sleeve for 6 months. Finding that the pain eases slightly with these measures and returns reliably without them, and concluding that their knee simply requires these supports to function. In almost all of these cases, what the knee actually requires is a properly structured rehabilitation program that addresses the reason the ice and sleeve were needed in the first place. One thing that often gets lost in conversations about knee pain, and that's worth carrying with you as you settle toward sleep tonight, is the difference between understanding your pain and being afraid of it. Pain that makes sense. Pain whose mechanism you can follow, whose triggers you can identify, and whose pathway toward improvement you can see, is far less distressing than pain that feels random, inexplicable, and out of your control. A large part of what we've done tonight is take knee pain out of that second category and put it firmly in the first. None of the 8 reasons we went through tonight is mysterious. None of them requires you to simply manage and endure indefinitely. Each of them has a clear, well-understood path toward improvement, available to the vast majority of people who experience it. The knee is, in a sense, a mirror of the whole system it lives inside. When the hip is strong and the foot mechanics are sound, and the movement patterns are efficient, and the muscles are doing their jobs, the knee tends to function quietly and without complaint for decades. It's when any part of that surrounding system starts to fall short that the knee, caught in the middle, connecting everything, becomes the place where the problem announces itself. Finding what's actually falling short and addressing it directly and patiently is almost always the answer. Your knee is a remarkably well-designed joint. It's built to carry you through decades of walking, climbing, sitting, running, and everything in between. When it hurts, it's almost always telling you something in the system that supports it needs attention. Not that the joint itself is failing. Understanding that difference, which is what tonight has been about, is very often the most important step toward actually fixing it. This has been educational content, not medical advice. Sleep well and take care of yourself.